It is costing around 7 or 8,000 rupees. That's it.
नहीं
Again, it is for this person. 50%
नहीं आया.
So Ishant Chaurasia is going to deliver lecture and video about MIPH and configure how to do MIPH, and he is going to organize the World One in Indore in 2026. So welcome, Ishant.
Good afternoon, everyone. First and foremost, thank you all the ISCP office, especially Rahate sir, Lauduka sir, and everyone for giving me the opportunity. I will bring greetings from Mandsaur, and I'll be talking about MIPH. For the fellows sitting over here, I think at the end of the entire FICP workshop, one should be able to understand clearly which is best: hemorrhoidopexy, hemorrhoidoplasty, or hemorrhoidectomy. Choose any procedure, but do no harm, as what the Hippocrates has said. So basically all these hemorrhoids, I'll just quickly go through it. It is round blood flowing balls, and we need to control all these round blood flowing balls. So we all have understood what the anatomy, the disease is a natural part. But you understand the indications for the MIPH, especially grade 2, grade 3 and grade 4. Now the latest version says that if you are having grade 4, go for a star procedure. So the patient position, as you remember, it's a pure anatomical surgery, like a hernia surgery is being a pure anatomical surgery. Similarly, hemorrhoids or MIPH is a pure anatomical surgery. The concept lies in the firing of the stapler, but before that, each and every instrumentation and the deployment of it. So hence, all these instruments have a very important role, and thereby the complications also happen through each and every part of it as well. So this part of the stapler, we all know, we should understand it, what is the end wheel, the shaft, how much housing has to be done, with the thread of ports, insertion, exertion is very, very important. When to lock, how much compression to be given, how to put the stapler, how to remove the stapler, everywhere the surgery can become a very smooth way, or it can become a very catastrophic traffic as well. First step, now anal dilatation is very, very important. A nice, smooth, gentle application of lignocaine jelly and pure dilatation, go both clockwise and anti-clockwise, very, very important. Otherwise, it will become very, very difficult to insert the obturator. Here lies, if you gently do a good dilatation, you will be able to put the obturator inside. Else, you will not be able to put the obturator inside. Now, along with the dilator, we need to put the obturator. Now, here comes the complication. We put the obturator and we are not able to identify the dentate line. If you are not able to see the dentate line, remove and redo the process. Otherwise, the first complication will occur, that you will not be able to do a pure mucopexy. So dentate line identification is very, very important. Secondly, the purse-string suture. Now here lies the crux of the entire MIPH procedure. If your mucopexy is not correct, your stapler will incorrectly be fired and there will be a bleeding, thereby leading to strictures and many, many things. So this is the pure first step. The purse string is the most important step is the purse string for the MIPH. So purse string suture, they are very different procedures. Some surgeons prefer to start with 3 o'clock, go to 5, 7, 9, 11 clockwise. I prefer to start from 6 o'clock, take a round suture. Some prefer to start from the 9 o'clock. Whatever you feel comfortable in, the entire purse string has to be done. And then the A-well insertion, do not open completely, be a partial open, and then gradually go inside and then see the opening to it. And then the thread should be passed from the either side and through the suture threader, and ideally some prefer to take a knot, the surgeon knot, some prefer to do it via artery force. Again, it depends upon the comfort to it. Closing is very, very important. The problem again lies in the closing as well, the complication. The closing should be exactly at the 90-degree angle, perpendicular to the ground level. It should not go hayward at 180 degree, 120 degree or 100 degree. If you are exactly in the parallel position, holding the gripping exactly at the same time, and the firing should be very tight enough. A noise, a crack, cut sound comes to it. If it is not coming, that means the staple is not fired completely. So we need to understand it should be completely pressed. Before that, in the middle of the line, it comes with the green that is safe to fire, and only then the safety lock opens it. In a female patient, always remember that one finger should be inserted in the anterior part, so that to identify that you are not firing up at the anterior part level, thereby creating a chaos. So I'll show a video, and then again the one more complication occurs is how to remove. Sometimes the stapler gets stuck and don't get removed. So do not get panic into that. Gently open and again through clockwise and anti-clockwise movements, you gently remove the stapler. Even if sometimes the stapler does not get removed, you can remove by opening remove the stitch from the obturator. Along with the obturator, you can remove the entire stapler. So in comparison, MIP is better. I'll show you the video to it. It's not working video. Video is not working. कर दिया सर. I'll show. So first and foremost, what to do first? The external part or the internal part? Always start with the internal part first. You can do a local infiltration. It is very, very important. Either you can take a purse string suture to it. If not, you have the Ellis forceps to it. Take an Ellis forceps and put it at a 12 o'clock position, 3 o'clock position, 6 o'clock position, expand it out. Because you need to have a proper visualization, only then start with the dilatation. So being the proper anatomical visualization is very, very important. Now see the dilatation. Do it both clockwise or anti-clockwise. Just do not try to penetrate or put it inside directly. You need to understand that the verge is very, very small and proper identification is very, very important. Now, along with that, again through the obturator, by going clockwise and anti-clockwise directional flow with good jelly, identify this dentate line. Till the time you have not identified the dentate line, do not go for the next procedure, because this is the prime important thing. Only then you will be able to start doing the purse string suturing, which is a mucopexy. You will be able to identify that you go between 3 to 5 centimeters, 3 to 4 centimeters, where you will start doing the mucopexy. You can use the preferred suture to be used is Prolene number 2 or Prolene number 1. It is available with most of the companies. They provide the Prolene suture to it. Now, for the beginners in MIPH, do not first and foremost take a very good bite. Thin bites are not acceptable. Take a very good bite, good gentle bite. Start from 3 o'clock to 5 o'clock to 7 o'clock to 9 o'clock. Do not try to take the huge bites of going from 3 to 6. You can take small but complete bite has to be taken. Complete mucopexy has to be done. This is the crux of the surgery. If the suturing is not correct, your staple will abruptly misfire, and there will be recurrences that the pile has recurred again, or the staple has misfired. You won't get a complete what you know as surgery. Now, take an alternative suture. If you are starting from a 3 o'clock position, to maintain the stabilization, you take an alternate suture at the exactly opposite side of the 9 o'clock position. Now, but if you are starting from the 6 o'clock position to do the suturing, you can take a complete suture, and when the other suture passes more to the 7 o'clock side, and you need not have to take an alternate suture to it. Now, talking about, see, I'm not supporting any industry, but all the industries have got a good staple available. It all depends upon what Rahate sir has told before for the laser as well. It is a problem that is created by the surgeon. Yes, sometimes that's a machine. There is some errors to it, but most of the time it is how our suturing is happening. So take time, take a suture threader, take both the sutures out, put a knot to it. One circle of knot is good enough to it. And again, before firing, put your finger to it. This finger is very, very important, your first finger, to feel that the bite and the knot is taken properly. Now, you can take either a knot over to it, or you can put an artery to it. But this is basically for the support, so that you do not loosen the mucopexy that you have already done to it. Now, gently close. It should be completely closed up. And see that there is a marker to it. Now this marker should come down in the green zone, only then your staple line will happen. And in a female patient, again, please ensure that the bite is not taken solely that the anterior one is fired. Press, I always prefer to stand and press it up. It should be complete press and you will hear the voice of cut that is coming, complete locking term. Hold for 20 seconds. And you can see, if you see that the bleeding has occurred, take a suture over it, prefer taking cataract or a Vicryl, recheck it, and that's it. So any company staplers, it's a bit. Now I'll talk about the complications too. So for the complications, I'll take a due courtesy that I've taken the presentation from one of my mentors, Dr. S.K. Nigam sir, and he's one of the pioneers of MIPH in India. So very important points, a very short 2 minutes that Nigam sir has given to me. It is completely an instrument dependent procedure and one missing staple can result in high bleeding. So what are the problems that happens in the beginning? If the biopsy is required, take it beforehand, before firing the stapler. This is the prerequisite to it. Now, you have to deal with some external components prior, after inserting and doing the Hemorrhoidopexy and firing the stapler. If you find any hyperpigmented papillas or anything, you need to wait. Uneven donor is due to uneven application of purse string. So this is how a proper purse string is deployed and go. A proper knot is taken. So it should exactly go. Now, why sometimes small donors come? We said complete donor does not come. It is because we have taken a too tight suture and very small bites have taken. So that is a good gentle thick bite needs to be taken for a proper mucopexy. The entire procedure lies upon your mucopexy. We need to understand it. So this is the ultimate breadth of the donor that has to become, and the pressure, how much has to apply is the gentle pressure with the first finger. Now, sometimes these are instrument defects that has occurred, which can be that these kind of staplers are sometimes you do not find. So always before firing, you need to check that it is completely closed. When it's not being completely closed, that means there is a staple missing. Every company has got different kinds of staples available, so we need to understand those points as well. Now, when there's some minor bleeding, either do cauterize. If you're not able to to control the bleeding, just take a complete sutures to it. Now, this is what sir always says, that you do not open too much and always remains it. And if it is stuck up, do not panic to it, because maximum times it happens that you are not able to remove the stapler. In that case, whether if you are not able to remove both clockwise and anti-clockwise rotation, that is the key. Do not directly pull it off. And even if not coming, then with the obturator, just cut the threads of the obturator and gently through clockwise or anti-clockwise rotation, remove it, and it will gently get removed under vision. Because if you try to pull it up, many a times that staplers also come out together, and then there's a torrential bleeding that happens. And sometimes you see some pile remains. So I said you have to do a hemorrhoidectomy part to it and remove the piles. On that note, I invite you to WorldCon, and there's a short video which I'll play in the legacy of Dr. Chevite sir. Why this WorldCon is something very different. Firstly, it's the 11th World Congress and all the fellows need to register for it to get the convocation.